Go right ahead.
Thanks so much, Diana, and welcome everyone. Good afternoon, and thank you for joining us for today's webinar on measuring your success. We are recording the webinar and we'll be posting it on our website in the next week or so. Diana pointed out the chat box below the slide. We want this to be an interactive conversation, so as we go through, please feel free to type in any questions that as they come to you. We'll be pausing at several points for discussion, and we'll also be asking at that point when we do pause for you to feel free to participate by phone. But for now, as we're listening to a couple of presentations, if you want to mute yourself, you can just press *#, and it's the same thing to unmute yourself. So we'll hope that you'll be participating as we go along. I just wanted to introduce you to a few of the SPRC staff on the call, and we're folks that you'll encounter throughout your grant. You just heard Doreen. She just joined our team a few weeks ago as a senior tribal prevention specialist, and she'll be working with several of you directly as your prevention specialist. She brings some wonderful experience in evaluation and suicide prevention work with Native communities, and she's joining us from her home office in Albuquerque, New Mexico. We also have Melissa Adolfson on the line. She is working part-time with our team as an evaluation scientist, and she's worked with a number of tribes and communities on epidemiology and surveillance. So we're very happy to have her joining us as a subject matter expert, and she's joining us from her home office in St. Paul, Minnesota. And on the right, that's me, Ellie Stout, and I'll be your moderator today. I lead our prevention support team. Sorry, we just renamed it, the State and Grantee Initiatives team here in the Boston, Massachusetts area, and we have staff all throughout the country, and our job is to support you in whatever you need to implement your efforts for your Garrett Lee Smith grant. And you also heard Diana Weisner on the phone. She's our technology specialist, and she will be sort of doing all the background to make sure everything's happening smoothly. We're also very pleased today to welcome some of your colleagues who have a few years of experience implementing GLS grants. So we have Bill and Rick, who I'll introduce in a bit more detail in a moment, and each of them will share some of their experiences with surveillance and data and measuring success. And we'll take questions after each presentation. And then we have quite a bit of time to talk with all of you about some of your initial thoughts of how you'll demonstrate impact throughout your grant. We know you're just at the very beginning, but I'm sure that you have some initial thoughts, some ideas that were in your proposal, and so we're hoping that we can kind of be a learning group along with the presenters of sort of learning strategies from each other. And I have a few next steps sort of at the end just to kind of let you know what to expect in terms of the kinds of support and conversations we'll be having around surveillance in the coming months. So before we dive into all of that, we wanted to get a little bit of a sense of who is in this virtual space with us. So if you don't mind, we'd love it if you use the chat box to introduce yourself. If you could share your name, the Garrett Lee Smith grant site you work with, and the role that you play on the grant. That will give us a chance to get to know you a little bit. And hopefully you guys can see who else is in the room in terms of your peers at Cohort 10. I see everyone's typing. I'll give you a few seconds. And as people are typing in, just go ahead and hit the Enter key and it should pop up. There we go. Oh, hi, Shane. I know Shane from a previous grant. Oh, great. We have at least one evaluator in the room. That's great. And Shane, I think, is more on the project director side. So it looks like we have maybe a mix of some evaluation staff and some program staff in the room. Great, program coordinator. I'll give folks a couple more minutes and then I'm going to go ahead and move along so we can hear from our presenters. But keep an eye on the chat box. Oh, there we go, another evaluator. And that'll give you a sense as well of who from your grant cohort is joining. Oh, and I should mention that we've also have Chelsea Booth on the line, and she's sort of here to represent SAMHSA officially, just in case there are questions about any grant requirements related to evaluation or surveillance. So thank you, Chelsea, for joining and sort of being on hand for any of those kinds of questions. So it's nice that we have a mix of project directors and program staff, as well as some evaluators in the room, and that's helpful, I think, for our presenters as well to orient them. And I'm going to go ahead and introduce our first panelist. Oh, and I'm sorry, Bill. Bill had a beautiful image on this slide in the blank space. I guess that didn't translate to the slides. So imagine a beautiful image, and we'll post the PDF of the slides as well on our website so you can see it. But just to introduce Dr. Bill Connor a little bit, he's a father and, as he says, pop to 5 grandsons with another on the way. He and his wife and family lived in Fairbanks for 27 years, and he's recently retired from the University of Alaska in Fairbanks, where he is a clinical associate professor of psychology emeritus. And during his time at the university, he served in various roles, including a clinician, a faculty member, the director of the Center for Health and Counseling, and finally as co-director of clinical training for the PhD program in clinical community psychology. And now he is a licensed psychologist in the state of Washington and serves as the project director for the Northwest Indian College GLS project, and that's a Cohort 8 tribal grantee. So they are currently in the final year of their project. And Bill, thank you so much for joining us, and I'm going to hand it over to you to share a bit of what your project has been doing around suicide surveillance. So please go ahead.
Thanks very much, Ellie. Can you hear me? Am I on?
Hear you just fine.
Good. Welcome all, and thank you all for calling in, and thanks to all the support people who are doing such a great job of making this happen. And thanks to Doreen for getting us started in such a good way. As Ellie mentioned, we are in our 3rd year of our project, and the first slide has the name of our project, was Witnessing Our Future, and I'll say a few words about that. Our program, the PI for the project is Stacy Rasmus, who many of you may know from other work she's done both in Lummi and also in Alaska. Dr. Bill Freeman is our evaluator. He was going to try to call in today, but had another meeting come up. Okay, I'll forward slides here. Oh, good, that one showed up. So this is one of our project logos. All of our work, the artwork, has been done by members of our coalition, and I'll say some words about that later. I'm not sure if you can read the top. It's a little blurry, but it says "For every youth a witness," and that is the guiding principle for our work. Those of you who know Coast Salish traditional beliefs probably know that the role of the witness is very important. It's an essential part of gathering, of collecting, of community processes and community healing. And so we thought that witnessing, for every youth a witness, or witnessing our future, is about witnessing for the youth in the community. This project was developed initially as as planning to be an implementation of the Model Adolescent Suicide Prevention Program from Arizona, and I'll say some about that later. And then also the work that Dr. Rasmus has done in Alaska. Next slide. Our project is focusing on two communities. One is the community of the Lummi Nation, so that the Lummi community is in northwest on the Salish Sea. There are approximately 500 members of the Lummi Nation, and the reservation encompasses about 13,000 acres of beautiful, beautiful country here in northwest Alaska, northwest Washington. I'm slipping backwards. We're also, part of our project are the students at Northwest Indian College, which is a college on the reservation. That college has about 1,200 students and comes from, over time, comes from about 90 different tribal nations. So it's quite a diverse population that we're trying to work with, or we are working with, at Northwest Indian College. I mentioned that there were two areas of focus. I'm not going to talk so much about the first one because it's more on the prevention side, and the other piece is more on the surveillance side. But the two pieces of our project, one of them is an attempt to adapt work Dr. Rasmus has done up in Alaska. This is a Ganasavik workbook or toolbox. And the purpose of this toolbox, well, first of all, the toolbox was developed by elders in several Yupik and Chupik communities in western Alaska. And essentially it is a gathering of modules, for education modules focused on the community, focused on family, and focused on individual, that have lessons in storytelling, making good decisions, healthy relationships, but it's all done, and it's all done from the Yupik and Chupik community perspectives. The focus of this is on creating and building strengths within those communities, and that is a piece that we're working on adapting here on the Lummi Reservation. The other piece of our work, and this is more of, I'll talk more about this today because this is our surveillance piece, was based, or is based, on the work that the White Mountain Apache tribe has done. And some of you may know that project well. Essentially, that project started with a tribal resolution, and the resolution charged the group who was presenting it to create local, detailed, and real-time data collection so that there could be incorporation within clinical settings and in-person follow-up for at-risk folks. And that's the piece I'm going to be talking about today, our adaptation of that for the Lummi community. So one of the things that we feel extremely is extremely important and also very, very happy about is that our project is completely coalition driven. So we have monthly meetings of anywhere from 20 to 30, 35 people from the community, and that consists of both employees on the reservation, but also Lummi elders, Lummi youth, school counselors, counselors in the mental health, Lummi mental health. So it's again a diverse group who bring many perspectives about this topic of suicide. We spent, and still actually spend some of our time talking about how we should speak about suicide. We've had discussions about this that have ranged anywhere from the old way was not to talk about it to how we can talk about it today, but not allow it to enter into the room, or not, or at times asking it to leave the room after we're done. So we've talked about how to approach this and how to make ourselves ready to be working in this area. The next thing we did as we proceeded through our process was inviting the White Mountain Apache group to visit Lummi. They spent 2 days, or I guess it was 2 days, on the Lummi Reservation, made a variety of presentations, both to our coalition and to Lummi elders, as well as to the Business Council, and talked about how their process developed, and gave us directions on, and that gave us some directions on how we might proceed. And again, I'll speak about that in just shortly. One of the things that we had originally identified in our grant was that we would do community screening. We brought some screening tools. We had lots of help from SPRC, brought some screening tools to several of our coalition meetings. And some of the elders were very direct and helpful in telling us that they would not do screening in that way. So we've moved on from that. Again, trying to follow particularly what the elders were having to say about how we all can identify youth at risk. We had a retreat with the coalition to further our ability to work together, and then began to talk about creating a resolution. This resolution has been shaped over probably 5, might be 6-month period of time. The idea was that we would create a resolution that would then go to the Lummi Business Council, and that the council would then be directing the community, or those who work within the community, to create a data surveillance, tracking and surveillance system. So we had quite a bit of discussion about how this would happen. We talked about the fact that we needed to also do training among people in the community to identify, respond to those at risk, and also to know about what resources were available. One of the things that came up during the shaping was the need for cross-departmental communications, and how then we could use the electronic health record to assist in this process. This slide I put in here just to give you an idea about what has taken us the 6 months, or 5 or 6 months in developing the resolution. Again, the goal of the resolution was to create was to empower the employees, particularly within the community, but also others, to develop the surveillance system. But each time we worked and massaged the resolution, we would then take it to another group. So we talked with all of these folks that are listed here and more that gave us input on what a surveillance or tracking system really could look like. So we talked with Health and Human Services, we talked with behavioral health, we talked with the health clinic. We spoke with a number of the agencies within the community, including Victims of Crime, Lummi Police, Tribal Attorney. And after each discussion, we found that we learned, number one, that we learned something more about what would work in terms of surveillance, and number two, what would help them or their agency buy into this process. And so while this took quite a while, actually let me go back, while this took quite a while, what I think we're finding is that the resolution, when it is completed, I think will be more complete than it would have been if we just developed it on our own or through our coalition. We've had to have quite a bit of patience because each time we worked on this, we thought we had kind of resolved issues of how to create this surveillance system. And each time we would meet with somebody new, we would get new ideas and things that they would suggest to make it a better system. So it's been a very much of a community process, community-driven, and has taken a while to be developed. We believe we're one meeting away from having a final resolution and then moving on to presenting it to the Indian Business Council here. So the resolution, just quickly, will help providers within both Lummi and Northwest Indian College track data. It will also charge several of the offices within the Lummi reservation to better respond. It will also work. It'll make recommendations regarding interventions, and then will also require reporting so that we all can know what's working and what's not working. So what we've learned, I think I've said a little bit of this already, one of the things we've learned is there's a wealth of resources. Again, as we met with each group, we found out more and more about what was available to community members and to the on the Northwest Indian College campus. What we also found is somebody needed to pull all this together. That overwhelmingly there was a discussion about needing to find better ways of communication across providers, but on the other hand, not require or have minimal requirements on staff time or other financial burdens. So we've tried to take that into consideration. A specific example, and I'll talk about this and then turn it back over to Ellie. One of the things that we found was that first of all, the GLS and the people that we've worked with for our grant through SAMHSA have been extremely helpful in terms of helping us to shape this process to the community. One example of that is the early identification and referral forms. I'm not sure if you all have learned about those yet, but it essentially is one of the ways of tracking and creating surveillance about who has been worked with and who is at risk. we found that both at the college and also in the community, that if we filled out all of the components of that and then reported all of the components of that, it was very potentially could disrupt or eliminate the confidentiality that we were promising people. And part of that was because the communities are small enough and the college is small enough that if we put enough data points together, it would be easy to identify the person. SAMHSA has been very good with us in terms of helping us to figure out how we can group data and report it, and that's just an example of how the data surveillance and reporting has been tailored to fit this community, which we're happy about. That's my last slide. Ellie, do you want to open for questions now, or have?
Yeah.
What? Okay.
Yeah. If you have a question for Bill, if you wanna, you can either type it into the chat box, or if you're muted, you can press *# to unmute yourself and ask your question. And while people are typing in or unmuting themselves, I was curious, Bill, I hope I didn't miss it in your comments, how long this process has taken, because it looks like you really worked through with each group, sort of getting their input and feedback and tweaking the different versions. So how long has this process been going on?
It has been 5 to 6 months. It has taken us to go from what we learned from White Mountain Apache. That's where this started. We started with their resolution, and we first sat down with the coalition and looked at that resolution. Our coalition more than tinkered with it. It did quite a bit of rewriting to fit this community, and then, as you said, from the coalition, then we met with agencies and individuals within the community and within the employee of the Lummi Nation, and each meeting took a week and then a rewrite and sending it back to our coalition. So it's probably been 6 months, but I'm knocking on wood. I think we're very close to having a complete document now. An interesting fact was we at one point the resolution had grown to 8 pages, which is, I guess, unheard of. They really probably should not be that long. We talked with the tribal attorney, and they recommended some ways of cutting it and creating a shorter resolution that would be very clear in terms of what the Lummi Indian Business Council was charging the employees to do, and then the rest of what we had written up through the discussions can be sort of a framework that they can begin to work from in terms of creating, or in terms of implementing the surveillance system.
Great.
Ellie, one of the other things that has come up frequently, not so much in the community behavioral health or the Lummi clinic, but the question has come up in the community as well as in our coalition, is why? Why are we collecting the data? And I think that we keep getting brought back to that, and I think that's a good thing because it's helping us to clarify. It's helping the coalition to clarify how data can be useful, and then also. One of the things I learned a long time ago was that if you're going to collect data, you should have a reason for what you're collecting, and I think that the coalition has done a real nice job of keeping us on point there, so that the data is not the goal in itself. It is how do we judge or manage what we're doing, and how do we find and then reach out to the appropriate people. As one of the coalition members said, she called it, we're not looking for data, we're looking for healthy data, and we've enjoyed that.
Mm. And I see Shane's typed in a couple questions, but just to follow up, in terms of sort of once the resolution is complete and the system's in place, what are kind of the next steps, and will you be sharing information back with the community now that you've kind of clarified what the information is for? Is that sort of part of the plan?
Yes, I think one of the things that has been important to us, and I think we've done a reasonable job as a team, excuse me, to do this is that this really is driven by the coalition that I think has a good representation from the community. So the surveillance system that the Indian Business Council hopefully will charge the community with setting up. A part of that is creating data that then would be de-identified, obviously, and then brought back to the community and to the council itself. Did that answer your question?
Yeah. So I'm going to just go to Shane's question. He had, if you look in the chat box below your slide, some questions about screening tools and follow-up. And I don't know if any of those questions also relate to the surveillance system in terms of how you'll be tracking some of those kinds of activities.
Yeah. Shane, thanks for your question. This has been a discussion that we've had within the coalition. As I mentioned, we took several of the standard ones to the coalition meetings, and several elders looked at us and said, there was a I don't know if I can describe the look, but essentially they said, I would never use anything like this. What I do is I look in the person's eyes, and essentially what we came back to was that, at least in the community, people generally know when somebody is hurting, and what they don't know is what to do and how to refer, where to refer, and that sort of thing. So the coalition is not recommending any screening tools. The Community Behavioral Health and Lummi Clinic have a variety of tools that their clinicians use, like the PHQ-9, I think it is one of the ones the Community Behavioral Health is using, and we're not making any recommendations to change what they're already doing. It's more about, our recommendations will be about more about the data. This second question, what type of follow-up will you guys do? One of the things I think we're hoping for is to have the surveillance in place by the time this grant runs out, and then find a way of keeping the team together so that we can follow up on what the data is looking like, and whether what we're hoping for, which is that people who perhaps fell through the cracks previously that's no longer happening. Shane's other question: are you going to implement zero suicide? It's interesting you asked this, Shane, since I just replied to an email from one of our coalition members who also is one of the behavioral health counselors, and her comment, we have been talking about zero suicide, and her comment was that she wants to see us focus way upstream of that, and I think and I wrote back in the email that I think this is going to be an interesting discussion. There is some talk of using the zero suicide tools, but as maybe you can hear in my comment about that, is there's also some concern among the coalition members that we want to do more than just responding when somebody is on the brink, that we'd like to go upstream much further. And that follows more of what the Gnostic was about, teaching, finding ways within the community for elders and others to help strengthen the youth so that zero suicide is not even an issue. I hope that answers your question, Shane.
Great. Thank you, Bill. And I don't see any other questions. I will mention that, and I'll refer to this a little later, for those of you who will be at the Garrett Lee Smith grantee meeting, there will be some content specifically around zero suicide and what tribal grantees have been doing in that area and some of the changes that they're thinking about making to make it appropriate for their communities. So, since there are no other questions, I'm going to go ahead and move us along, and we'll have more time for other questions and conversations. But first, I'm going to introduce Dr. Rick VandenPoll, our second panelist. Rick serves as the director of the Institute for Educational Research and Service and is the principal investigator for the National Native Children's Trauma Center, and both of those are at the University of Montana. And the Institute and the Trauma Center address treatment of childhood symptoms of post-traumatic stress, suicide, emergency management, and recovery. Rick has been a professor at the University of Montana for 35 years with tenure in education and psychology. And before joining the university, he worked as a classroom teacher, a psychologist, and a school bus driver. And Rick was the principal investigator for the Garrett Lee Smith Tribal Grant that was implemented by the University of Montana in partnership with a reservation in Montana. And this was a Cohort 6 grant that had a no-cost extension, so it ended last year. And so Rick is one of our alumni grantees, and we're very glad that he was willing to join us today. So Rick, I'm going to turn it over to you to share a bit about the surveillance work that you did with your GLS project.
Oh, thank you so much. I had a chance to meet in preparing for today's work, a chance to meet with Bill and our facilitators a few days ago, but I really learned a lot from your presentation, Bill, and I was really struck by the overlap in the experiences that you have had with the work that you're doing now and experiences that we had in the grant that we were working on ending, as Ellie said, last summer. Like your work, we tried as much as possible to rely on cultural traditions and strength building, to move away from pathologizing, which has been, I think, maybe a bit too common in our field. We were influenced mightily by the work of the White Mountain Apache and met with them multiple times by phone and read their publications. One of the issues Bill brought up a moment ago about not talking about suicide was very much an issue where we were working, and a strong belief, including from terminally degreed psychologists, that just because something is generally true for the nation doesn't mean it's necessarily true in their sovereign nation. And so there was real concern about inviting suicide into the room by saying the word. And eventually I believe that was resolved, but it certainly was a source of tension in the beginning. As Bill said, we also found SAMHSA and the SPRC extremely helpful. We frankly got off to a slow start with a number of delays and challenges in launching, and We also struggled with the EIRF form, and we're very pleased by the responsiveness of SAMHSA to some of our concerns that in a very small frontier community, birth date and etiology and date of service pretty much can identify the individual involved. And so we also were able to develop grouping or aggregating systems that ensured privacy. The work of a university in a sovereign nation is one always fraught with tension. I'm not native. I didn't grow up in that community. And our philosophy and our method of practice is to only go into a reservation community when invited, and unless the tribe or tribes explicitly request that we do so, we do not name them. As Bill described, the importance of establishing suicide prevention and surveillance was recognized by the Tribal Executive Board in this community, who passed a resolution with the number that appears on your slide, endorsing the work and endorsing the partnership with the university. In addition to pointing out the tension that exists with an outside university professor attempting to assist with a public health crisis, I need to also note that my remarks today are my own conclusions and not those of our partner tribe, nor SAMHSA, nor the university. The setting where the work occurred was a very rural reservation in the northern plains within the state of Montana, more than a 500-mile drive one way on two-lane roads. So there was, in addition to the challenge of culture and community and organizational missions, there was a simple challenge of physical distance. We were able to be there at least once a month and sometimes more often than that. And we met electronically, telephonically, and otherwise at least every 2 weeks and often once a week. We were invited to address the public health crisis in 2010. There had been a cluster of youth suicides in one very small rural school, enrollment about 200 students, that lost 5 of its students. So we were pleased to be invited, but also a little bit daunted by the magnitude of the task. And I think it may be the case with many of the current grantees, in addition to being a bit of a challenge to get things launched. When there has been a crisis, there is, I think, a very natural inclination for people to wonder why, and sometimes to even move that wondering why into a kind of blame or accusation, especially among individuals who have lost loved ones. All of the information I'm sharing today has been shared with our partner tribe. We had regular meetings before the full council or the Health and Human Services subcommittee, and we're grateful for their encouragement that we disseminate some of the things that were learned. The University of Montana doesn't claim any particular expertise or magic solutions or panaceas. We were part of a much larger coalition, including the tribe, the Indian Health Service, 2 local private hospitals, the Tribal Health Program, several school districts on and just off the reservation, Bureau of Indian Affairs, Child Protective Services, the County Sheriff's Office, which turned out to be very important for us because they were the central dispatch source for all emergency responses, medical or law enforcement. A number of different agencies might respond, but the call to 911 always produced a response from that central dispatch office who kept very good records. And as we moved forward through the project years, they began adding more and more information to better help them and us understand the circumstances involved with ideations that produced a call to 911 or to attempts and completions. Emergency medical, of course, was part, and a very major set of partners were the corrections facilities. There was a separate one for tribal youth and tribal adults, and yet a third for non-native prisoners. The effort to address the public health crisis in this community included a series of Garrett Lee Smith funded activities, 49 suicide prevention workshops over the 3 years. The hospital employed a grant, SAMHSA grant paid therapist and a case manager. The therapist saw over that time 174 unique clients. And some of them only one time during crisis, and some of those several times. But I must admit to a typo. I held the number 2 down too long. There were not 227 individuals, but 27 individuals who had 10 or more visits with a therapist. In order to understand the nature of the problem and the impact of the solutions being attempted by the various members of the coalition, we were able to create information and data sharing agreements with a number of key partners. One of those was the Indian Health Service, and part of our permission to review their data and discuss their clients and patients anonymously was predicated in our agreement not to disclose any of those findings outside of the program management activities of the grant. So even in the final report we submitted at the end of the project, none of the data from the local service unit are included. They had at full staff, they had 5 mental health, behavioral health providers, and so the number of clients was well above 100. But again, our agreement is not to disseminate any data resulting from the limited permission we had to talk with them and to try to understand the work that they were doing. Over the course of the 3 years, the County Sheriff's Office responded to some 200 calls for urgent help, and probably another 50% of individuals served by the grant either presented themselves for services at the Indian Health Service clinic or after hours in the hospital emergency department. A lot of our work involved training the emergency room physicians and providers in brief suicide assessment and screening using the SAFE-T model. And we also did a lot of training of gatekeepers, as I'll share in just a moment. What I think is unique in this project and in the surveillance that was done is that all of the partners to the coalition but one signed off on a HIPAA and FERPA compliant agreement to exchange confidential patient, client, and student information. The university has a permanent agreement barring us from ever knowing the name of any client, patient, or student served under the grant, nor to ever interact directly with one of those people. In so doing, we were able to further insulate the community from the potential pathologizing that comes from surveillance systems, while at the same time having some pretty important measures of the nature of the problem at the beginning and at the changes that occurred because of a community-wide agreement to take the problem on and make it better. SAMHSA funded the full-time therapist and a full-time case manager in the hospitals. The tribe's suicide prevention program director in the tribal health department was also funded by the grant. The grant also paid for data sharing and follow-up interview costs with the 9/11 emergency dispatchers. Other sources of support included biweekly and sometimes weekly discussions with IHS, data sharing with IHS, but they were terrific not only in attending every meeting and training that was offered, but also in asserting that their mission already included providing these treatments and declining any form of supplemental funding from SAMHSA, despite the real scarcity of resources that affects the Indian Health Service system nationally. The Sheriff's Office conducted an annual youth wellness event, including a t-shirt contest. The best t-shirt celebrating life was silk-screened onto several hundred shirts. There was a community feast and a candlelight vigil. Those sorts of activities typically are not supported with SAMHSA funds, but we and others, including the governor's office for our state, were able to contribute. So the surveillance system that we used involved multiple sources of information. The two grant-funded employees, the therapist and the case manager at the hospital, met with us extensively. They also were invited to join the Indian Health Service behavioral health team in their daily breakfast meetings where patient status and treatment was discussed, because there was such frequent sharing or joint treatment of a patient or client in both the hospital and the IHS. So again, with the IHS, we had a limited data use agreement with no permission to disseminate information. With the Sheriff's Office, we had a data use agreement that does permit information sharing. We have feedback from workshops and other trainings and multi-agency meetings, in some cases more than once a week. There were interesting findings that surprised me. Looking across the board from all the data sources, hospital, IHS, and Sheriff's Office, not unique to IHS, the highest prevalence of suicide risk was Tuesday in the evening or night. Recent data released by our state suicide prevention coordinator, Carl Roston, indicates that this is also the case statewide. All days of the week had completions, ideations, and attempts. Weekends tended to have the lowest rates. Those data come from interviews conducted with the client seen in the hospital by the therapist. Not all of those individuals agreed to be interviewed, and so their information is not included. So it's a subset of the 170-some people seen by the therapist in the hospital. What was also interesting, the most common means and methods in this community appear to be different than the rest of the United States, and some of the reservations that have published those data. We believe that underscores the need for local solutions, and it underscores the importance of confirming that if something might be true in general, it might not be true in any specific community, and we need to answer in that community whether a fact is a fact or whether it is a discrepancy. We did see that people with previous attempts were at the greatest risk of subsequent attempts. We provided case management, attempting to emulate the model of the White Mountain Apache, and it proved far more challenging than we had anticipated. It was very difficult sometimes to engage individuals who had been seen. We don't know for sure, but we have some hypotheses and opinions that stigma might contribute to people giving incorrect phone numbers and simply not endorsing that they are the person who was being sought when the telephone was answered. Of the 69 people who had attempted, 27 of those had attempted previously. The most frequent means and methods for both youth and adults were drugs, alcohol, and other toxins, followed by hanging or suffocation and cutting or stabbing. And unusually, firearms were used very infrequently in this community, which is very different than the state of Montana and also very different than other reservations that have published means and methods for their public health challenges. We did not, in my opinion, focus sufficient resources on case management. We were able to follow up with 52 people who had attempted or a sentinel report or a loved one for wellness checks, but that meant about one telephone attempt out of 3 produced useful information, 2 out of 3 did not. Those people providing information generally reported that the individual about whom we were concerned was doing acceptably well or well. Other findings that came from the interview, from the BIC interviews conducted by the therapists in the hospital, is that 53 of 68 people attempting reported there was someone physically nearby at the time. We think that has significant implications for safety planning. We know that contact with an at-risk person is crucial for their well-being and safety, and we've modified the protocols for individuals released from the emergency room to their families, encouraging that families do ask the question of whether the individual is planning to attempt or complete. It's also recommended that individuals not be allowed to seek privacy by closing the door, including in the restroom, because the means and methods include those that I described. It makes access to instruments very difficult, coat hangers, bed sheets, even the safety room in the hospital for patients at risk had to modify a lot of its procedures to keep highly at-risk people sufficiently safe. We also think that continuing suicide awareness training is really a good idea, and there's been continuing trainings provided locally, including in mental health first aid and the zero suicide model. Finally, one last important finding, over the course of the grant, not one client who was actively treated by either the IHS behavioral health providers or their hospital therapist completed by suicide. And last, these data come from the sheriff's office, and they show the rates of suicide completion in 2008, the year prior to the cluster. The cluster occurred in the 2009-10 school year, so those bars would be stacked for the gray data sets, the juveniles. The overall rate of adult and youth completions steadily declined from 2009. In 2012 and 13, the rate of youth suicide completion was 0, and in 2014, on New Year's Eve, 1 male completed suicide. Similarly, the attempt rates for adults and youth, with adults, the bold black bar on my computer screen, and the juvenile rates, the light gray bar, those rates showed the similar pattern, increasing in 2009, 2010, and then a steady decline through 2011 through 2014. What we have learned is that all of us are interested in eliminating completions, but it's a difficult metric to reliably measure. There are a variety of reasons why an unattended death might be referred to as a suicide or might be referred to as having a different cause of death. Typically, it is a determination made by the coroner, but that's not always the case. Some of the deaths occurred in the hospital. In that case, the hospital record provided that. We think attempt rate is really important to measure as all of us attempt to learn about and improve this terrible public health problem. The attempts often have witnesses. Attempts often have evidence, and attempts do not have the same degree of stigma as completions. So we believe that measuring attempts is very fruitful, and we did measure but could see no clear patterns in our efforts to track ideation. Some of the local experts explained that the numbers of individuals experiencing ideation at some time was extraordinarily high, and they had to set rather limiting criteria for how a person would be included in their electronic health records. Specifically, they had to endorse suicidal intent and either have a plan or a schedule for their attempt. Otherwise, it was simply not included in the electronic health record. This last slide is my contact information, email address, and telephone number, our website, and also an acknowledgement of the great work of my colleague Marilyn Breer-Zimmerman, who served as the program director for this grant. She left us in November to accept a position as the senior tribal policy advisor to the administrator Listenby in the Office of Juvenile Justice and Delinquency Prevention. Her successor is an equally accomplished individual. Megan rides at the door, and I look forward to introducing her to you all sometime in the near future. Thank you so much.
Thanks so much, Rick. It's really, really interesting data that you guys were able to gather, and I think so clear that there's some implications for prevention efforts moving forward, and also really interesting to see the changes in rates and the decrease, particularly in the attempts that you saw during the project. So thank you so much for telling that story. Does anyone, if you have questions for specific to Rick, and then we're going to move to a broader discussion, but wanted to give people a chance to either type in a question or feel free to hit *# if you want to unmute yourself and ask in person. Sounds like maybe somebody unmuted. No? Rick, I'm wondering if you could just speak a bit to whether you're going to be sort of where you all are now. I know the grant ended. Is any of the surveillance continuing through the tribal health department that you know of? And do you know whether any of the sort of details on sort of methods and circumstances of some of the attempts has been used in continuing prevention efforts?
Yes, in both cases. The Sheriff's Office, we've maintained the agreement with them in a very small contract with their reporter who shares with us monthly their 911 dispatch calls for ideations, attempts, and completions. Because this is a very rural community, people tend to be aware of the circumstances of other people in their communities. And so very often it's possible to get a little bit of qualitative information on the circumstances surrounding one of those events from the chief dispatcher. The information that we obtained on prevalence rates, with Tuesday nights being a time when we need to have the most resources available to deploy, continues to guide staffing patterns in the hospital, as well as the on-call system with the IHS, behavioral health providers, and with law enforcement. The information on use of alcohol and other intoxicants, the very surprising finding that nearly 3/4 of all attempts said that someone was physically nearby, and the information on means and method all provide guidance on better ways of developing and implementing safety plans.
Okay. And it looks like there is a question in the chat about your experience with zero suicide. I don't know where that is. You had mentioned that that was one of the initiatives during the project.
Zero suicide was something that we became aware of in the last year of the project, and it was not in our original proposal, so our knowledge of it has been gained really quite informally. It's my understanding that quite recently the National Indian Health Service Office in Rockville has adopted zero suicide as their prevention model of choice, and so they're investing, in my opinion, appropriately, resources and training of their providers in zero suicide. My impression is that it is very good. I do not have particular expertise and shouldn't go much beyond saying that this is something that we all want to learn more about. I think Bill asked about the HIPAA and FERPA agreements. The standard for what is compliant with both HIPAA and FERPA seems to be evolving, and so the agreement that was formed for this project was done in the 2009-2010 school year, and it involved memorandum of understanding among the coalition partners that included language driven principally by HIPAA, and generally FERPA concerns were addressed in that. I think now the nature of formal HIPAA agreements has become much more sophisticated, and I know there are a lot of people paying attention to that nationally, and so it's so crucial that therapists be able to talk with school teachers and be able to talk with police officers about individuals who may be at risk, who we're concerned of, and whom we care about.
Great. I think that our colleague from SAMHSA, Chelsea, had a question for both of our panelists. So Chelsea, did you want to ask your question.
Hi, yes, thank you. And so I want to also introduce myself to everyone. Hi, I'm Chelsea Booth. I'm the State Tribal Coordinator from SAMHSA. Some of you have met me virtually. I've started to send you all emails about track, and soon there'll be more about the grantee meeting. So I hope to meet as many of you as possible at the grantee meeting this spring in DC. But my question for both presenters, your presentations were amazing. I have to say my mind is a little bit blown by what you've both been able to do in your communities. But I'd like to hear from each of you, like what do you wish that someone would have told you before you started this process? And it can be anything. I mean, it could be, I wish someone would have told me that it would take 6 months to get the tribal resolution drafted. I wish someone would have told me, whatever. But I'd like to hear that from both of you, if you wouldn't mind.
Well, thanks, Chelsea. I've asked myself that question, and my colleagues and I reflect on it regularly. I think probably two things, and related. The first is we were very ambitious and aspirational in our grant proposal, assuming that we could do things at great distance with a very complex system that took much longer to do than we ever thought would be the case. The second maybe is even more central to the work that was done, and that is people will not share information unless they trust you, and the only way to build trust is through relationship. And for us, that meant showing up both by telephone as well as in person frequently. Even so, it was I was very surprised at how long it took for us to achieve some of our milestones. And again, I'll echo Bill's remark a moment ago. We enjoy a fabulous relationship with our SAMHSA program officer, who really understood and helped us and tolerated delays that were embarrassing. But I think to assume that everything's going to fall into place as you wrote about it in 25 double-spaced pages is at best optimistic.
Rick, this is Bill. That was wonderful summary. I wouldn't have much to add. I think your last statement there about the optimism of our proposal and how that compares with the speed at which we're accomplishing things is well said. Chelsea, thanks for your question. I think one of the things I would go back to, I would go back to is I mentioned the need for patience, and Dr. Stacy Rasmus, who is the PI for our project, has done a great deal of this work, both in the current community that we're working in, but also up in Alaska. And she kept telling us to trust the process, that we needed not to be directing the process, but rather letting it unfold as it would within the community. And I think she's right. I think that's one of the things I would say to you grantees is that it's so important to get the community group together and then to trust where their wisdom takes the project. We provided some guidance, and we had good help from Courtney from SPRC, who helped us with specifics, and from Angela and others from SAMHSA. But the community and the process that the community goes through need to be trusted. Our coalition meetings at times we would have an agenda, and at times we would not talk about anything on the agenda because the coalition members came in with something that was current in the community, something that had happened or was was affecting them, and we would spend the whole 2-hour meeting discussing that issue. And that needed to happen. And once that was done, then in the next meeting we could move on to whatever's on the agenda. So patience and trusting the process, I guess, would be the things that Stacy said, and that I wish I had listened better.
Thanks so much for those words of wisdom. And I'm kind of curious what those new grantees in the room, though I know some of them have worked on previous grants, I'm curious where all of you are in terms of thinking about setting up some systems to gather some data, ways that you plan on showing the success of your 5-year grants. And I thought a place to start that you may be thinking about right now as you're sort of gearing up your work, I think it's really striking how both Rick and Bill talked about their work with partners, and we emphasized that those relationships were really key in their success. So what kinds of partners are you all engaging? Are there other partners that you're planning on working with to gather some information and data that haven't been mentioned? Who would like to share a bit about your plans? And it's fine to type something in the chat if you'd like, but we'd love to hear from you. I'm sure your colleagues would love to hear from you about how you're getting started and building some of those relationships. I see Barbara is typing.
I'll share. This is Shane in Portland, Oregon.
Hi, Shane.
So some of the partners that we've reached out to for this GLS grant, we work for an urban Indian nonprofit organization, and so we'll serve the urban Indian population in the Portland metro area. And then throughout that, we partner with 8 of the federally recognized tribes. There's 9 here, but Umatilla actually has their own GLS grant. So we partner with those 8 tribes. We also partner with Lines for Life, which is the suicide hotline. We partner with the Native American Youth and Family Center, which is the Native American high school in the Portland area. We partner with the Northwest Portland Area Indian Health Board, who actually serves the 43 tribes of Washington, Oregon, and Idaho. We're partnering with Oregon Youth Authority for corrections, Portland State University for our higher education, and Title VII Indian education out here, and also Chemawa, which is the Indian boarding school, which is in Kaiser, close to Salem, the capital. And so from each of those partners, we obtained a letter of commitment prior to accepting the grant, obviously, or being awarded the grant. But in that letter of support, they kind of outlined things that they were going to do, and so we'll be looking to kind of finalize some contracts and things like that right now. And obviously, we're always looking to partner. So as new resources become available, we look to partner. Some of our partnerships will be kind of more specific to maybe some outdoor experiential-based learning stuff, since we're choosing Project Venture as one of our evidence-based practices. So we might partner with like a rock climbing club or something like that. So I can see definitely more partnerships and MOUs being formed down the road. As of tracking for surveillance data right now, NAR currently uses the PHQ-9 and SPRC, and what we're talking about is when somebody screens positive from one of those, what's the next steps that we're looking at doing. So we've been looking at the Columbia short, actually, and a couple of their models that we've looked at off of the Zero Suicide website, and which ones would be effective. NAR is kind of unique in the sense that we have multiple sites and programs that are kind of in each site, and so this grant is housed in the youth department, so it falls under my prevention program, but really we're going to be incorporating it across all of NARA's health spectrum, and NARA provides adult mental health, youth mental health, alcohol and drug treatment for inpatient and outpatient. We have 2 full functioning health clinics. We're starting up a dental clinic. We have our prevention program. We have a Knock-Newit mental health youth program. So we have a number of different sites. And what we've decided in our first kind of steering committees, which was formed around trying to get kind of zero suicide off the ground, is we selected a site that we want to implement at first, which is going to be our outpatient program, and kind of looking at the next steps for that of, doing kind of our workforce what's it called? Is it the workforce survey? I can't remember. Oh, the organizational.
Yep,
the self-study.
The self-study. Mm-hmm.
And then we're going to do kind of the workforce survey after that. Before we do our QPR training and assist training that we're going to do, just so that we have a good baseline data for that, for where we've kind of come from to where we're going to be. And I think kind of those steps are really those next ones for us. We're going to look to contract with Ursula Whitehead, who a number of tribes have used. She's a non-native person that's had really good reviews in replicating the zero suicide training in tribal communities. So we're going to partner with hopefully the health board to kind of help us with that connection. And so yeah, those are kind of our next steps and processes.
Hi Shane, this is Spiro Manson. I'm the lead evaluator for the Fairbanks Native Association in Fairbanks, Alaska, and previously with the Tanana Chiefs Conference in their prior GLS grant, and of course they have another one in place now. My association was, in hearing you talk about the screening, brief intervention, referral for treatment, the SPRC initiative that you employ in your agencies to identify. We've been doing that at Tanana Chiefs Conference, both in the Chief Andrew Isaac Primary Care Clinic in Fairbanks for about 7 years now. And we've rolled that out in the last several years to the behavioral health associates in 6 of the 42 villages in the interior, in the subregions. And we worked through a lot of the issues around the protocols for not only detection but subsequent triage and managing at the various levels of intensity. So I think the program staff there, the RGLS project is entitled Visions. I think people would enjoy the opportunity to share the lessons learned and some of the tools that have developed over the years.
Great.
Great. Yeah, that's really cool. And unfortunately, we're running a little short on time, and I'm so glad that you mentioned that, Dr. Manson. I'm hoping that those of you, especially who are evaluators on the call, if I'm skipping kind of to my second bullet here, but we do have a community of learning for the evaluators for tribal Garrett Lee Smith programs. We have a separate one for states just because we recognize some of the challenges and strategies can be different. And that group meets every other month. It's sort of a drop-in group. If you're interested in joining, you're welcome to join. We know people are really busy, but it's really a chance to get together with peers, and Melissa also joins that conversation to keep an ear out for anything the group maybe doesn't have internal answers for, so we can gather some resources and information. So definitely ask your prevention specialist if you want more information. This slide has a few other sort of upcoming items on surveillance, but before I move into those, I just wanted to ask Chelsea one more time. I think she had a closing comment as we start to wrap up here.
Thank you, Ellie. I just wanted to make sure, and I'm sure that your amazing project officers have already said this, but I just wanted to reiterate that our goal at SAMHSA is not for you to get this information, these data, for us, right? Our goal is that you have the information that you need and you can use it to prevent suicide deaths of youth in your community. And although it's wonderful when you're able to share data, particularly evaluation data, because, you know, we are able then to draw some conclusions from it and frankly help other communities and other tribal groups who've either not been successful or have never applied. And so, you know, those kinds of information can be really helpful. But again, that's not our goal. Our goal in these grants is for you to save lives in your community. And so, you know, again, it's really not about what you give to us at SAMHSA. It's about what you need and what you find useful, and that also can help you show the impact of all the good work that you do. I mean, I remember in the second presentation you talked about learning that firearms are used less frequently. And we know that there's never enough staff, there's never enough money, there's never enough time to do all the things that we would like to do. And so having this information, particularly information like that, can be really helpful for you to do that strategic planning. So I just wanted to kind of say that as a funder, remind everybody that, you know, when you have questions or if you're having issues with confidentiality and you're not sure, you know, what you'll be able to share, you know, I know there are requirements in these grants. I know that we have things we're supposed to report to Congress. But at the end of the day, what we care about is saving lives. And so your project officers and I and everyone in the suicide prevention branch will do our best to make sure that you get the flexibility you need to save the lives of the youth in your communities. So that was all. Thank you very much, Ellie. And thanks, everybody, for attending today.
Yeah, thank you. Those are some great closing thoughts and comments. So thank you so much, Chelsea. And as you see, we'll be continuing this conversation on monthly calls. And I mentioned that the grantee meeting in Washington, D.C., for those of you who will be there, there'll be some surveillance content there as well. And we'll be in touch with everyone with some additional information. Pamela asked if we could send out the information to this group around the community of learning, so we'll do that. But I wanted to thank all of you for joining us and for participating. Thanks especially to our great presenters. We really appreciate you sharing your stories and the great work that you've done. We will be posting this webinar on our website, and we'll include the slides in case you could only join by phone. And my contact information is on this slide. And hopefully you're already connected to your SPRC prevention specialist, but if you're not sure who to get in touch with, feel free to write to me and I'll nudge you in the right direction. We're all really looking forward to working with you throughout your grants. So thank you so much and have a wonderful afternoon.
Thank you.
Bye, everyone.
Thank you all. Bye-bye.
Thank you.